of all, obviously, healthy lifestyle is going to go a long way. Anything that is good for cardiovascular health is going to be good for sexual health. So think of all the healthy lifestyle stuff. Also, nitric oxide is something I think is really important to think about. Who knows about this? Okay, good. So nitric oxide is a messenger, chemical messenger that is responsible for a lot of things. One thing is that it helps with vasodilation, so opening up the blood vessels so you can get better blood flow to different parts of your body. As you get older, so if you look at this chart here, when you're 20 years old, you've got a lot of nitric oxide, and by the time you're 40, you've got about half as much as you did when you were 20, and that just keeps going down. Now, certainly a healthy lifestyle will help to slow that downward trend, but it's not always enough. So that's one thing to keep in mind, is that when you lose nitric oxide, then those blood vessels, they're filling with plaque, and they now can't open up. So you have these sort of two double-edged sword happening. So things you can do all the good healthy lifestyle stuff, all the exercise, get a little sun, you eat your nitrate-rich foods, which are going to be like green leafy vegetables and beets and things like that. You want to try to avoid overusing antiseptic mouthwash, which is going to prevent your body from making nitric oxide from those foods. And if you can, also avoid any acid-blocking medications that are going to be also preventing your body from making nitric oxide. So that's things like Zantac and Protonix and medications like that. And then there's a lot of technologies out there now that can also increase nitric oxide. Things like red light therapy, which you've seen, hyperbaric oxygen could do it, a lot of supplements can do it. And then, of course, you have like the PDE5 medications, like Cialis and Viagra, which if you've been in this space for a while, you know those medications have a lot of, they're interesting in the longevity space for a lot of reasons, improving endothelial health, the health of the blood vessels, and continuing to get blood flow to all the body. And these medications do work in women, just as they do in men, if the problem is lack of blood flow. So they don't help your husband be nicer to you, but they do help if it's a blood flow problem. All right, speaking of hormones, this is one of my favorite topics. So about 30% of women stop having sex during perimenopause, which is that menopause transition, sometime between perimenopause and menopause. And if you're thinking this is only about 50-year-old women, women commonly start perimenopause between ages 35 and 40. And a lot of women start even earlier than that. So this is not a disease or a problem of, little older women. This is a problem for a lot of women, even younger women in their 30s. When you're 50s, about 50% of women report low libido, and we just, of course, see less and less sexual activity as people get older in general. So this is the menopause transition that Joshua was talking about a second ago. And you can see I put a little figure in here, this little lady right here. So she's just about to go down, that's her estrogen level, right? So she is about to fall off this cliff that is menopause, happens sort of during perimenopause. And essentially, estrogen dives down to, not zero, but pretty close to it because the ovaries stop working, which you just heard about. And this is a big problem. If you can see on this chart, at the same time that estrogen drops, you have this big increase. And this is showing cardiovascular disease and diabetes, which shoot up as soon as your estrogen goes down. We also see an increase in lipids, in visceral fat, in hypertension, in dementia, in osteoporosis, in sarcopenia, like all the things, because estrogen is so important. So this is a longevity event. So I should talk about longevity really quickly, because you do need to be alive in order to have sex, it turns out. So I'm a big fan of replacing hormones until we can get your ovaries to work for longer, which I'm a big fan of all this research that's being done. But until we have the ability to extend the life of our ovaries, I believe that replacing these hormones with bioidentical hormones is a very good option. We know from multiple studies, including over 30 randomized controlled trials in women, that when you start estrogen therapy early in menopause, which is usually between less than 6 to 10 years, after menopause onset, then we see about a 30 to 40% reduced all-cause mortality rates in those studies. What other drugs do this? There aren't any. In women, there are not any other drugs that will give you this kind of reduced all-cause mortality rate. We also know that estrogen is fantastic for cardiovascular health. I just talked about blood flow. This is a great way to keep your blood flow. Also, estrogen actually is a nitric oxide activator, and it also helps with just general cardiovascular health. We know that early onset estrogen use in menopause reduces cardiovascular risk in women by between 30 and 50%. That's the number, cardiovascular disease is the number one killer of women. So if we can reduce that, that's also good for your sex life. So I call this the sexual response snowman. And you can see here it's desire, arousal, orgasm. And then you can see some of the hormones that are important for these different pieces of this snowman. And I've circled the ones I think are the most important in this. And so estrogen, testosterone, progesterone, those are the three that all continue to go down, at menopause and just through life. Testosterone kind of goes down more slowly, like with men. In women, it's just kind of slowly goes down starting at about age 25, and it's just this slow downward trend. So they're all important. You can give estrogen systemically, meaning that I give you something that works for your whole body, and that's what I was talking about before with the cardiovascular disease and the just general mortality benefits. You can also give estrogen just vaginally in a low dose that just stays in the pelvic floor. This is an excellent drug. If you are someone or know someone who is over the age of 45 or 50, tell them that they need to be taking vaginal estrogen. That's it. I hope you know them well enough to say that. But if you do, tell them that. Because we know that this keeps the pelvic floor healthy. So it's, it's reversing all the things. Imagine, just for a second, imagine if we said to men, so when you turn 50, your penis is going to shrivel up, it's going to dry out, it's going to be invaded by microbes that are going to cause you to get all kinds of infections, urinary infections, yeast infections. It's going to be painful to have sex, and it's going to be awful. And by the way, you'll have to just suffer through it. Imagine what would happen. We would never do that, right? And yet we tell women this all the time because we don't give them this drug that costs less than $30 a month, is completely safe, even in breast cancer survivors. We have lots of evidence of that. And so we should be giving women this drug. Okay, that's important. Testosterone also should be used in women if they need it. Not all do, but if they do, then it's certainly important. Women actually have more testosterone in their bodies, usually than estrogen when they're premenopausal, and so somehow we forget that and we don't give it back to them. But testosterone is important for sexual health for sure, as well as for everything else, building muscles, motivation, just getting ready to, or your mood to do things. And there's plenty of studies now, about 36 randomized controlled trials that show us that even a low dose testosterone patch in women helps significantly with low libido and arousal problems in women. It works much better than any other FDA-approved drug out there, and yet we have no FDA-approved testosterone for women, which is ridiculous. But testosterone is important. All right, last little bit. I have no idea how much time I have. I'm just talking. But the last part is the support the structures. So after you have everything else in place, what else can you do? A lot, it turns out. Some of them more research than others, but this is some of the regenerative modalities that are out there. Some of them are available right now. Most of them are somewhere. Everything from, and we'll talk about some of these, some different biologics like stem cells and exosomes and things like that. There's shockwave therapy, hyperbaric oxygen, low-level light therapy. These regenerative biologics, when we look at them for sexual health, we're basically trying to do a few things. We're trying to increase new blood vessel formation, so angiogenesis. We're trying to repair the smooth muscle cells that they're no longer elastic anymore. We want to go back to them being elastic. We're trying to improve the nerve health and potentially, I got a bug in my nose, potentially grow new nerves or replace the nerves that were kind of broken. Reduce inflammation. We want to repair fibrosis or scar tissue, and of course just support the structures in that area. Or as I like to say, we want more reliable erections and O's. Which I think is really funny. Okay, so this right here is a picture of a kind of a complex picture, but we're looking basically at a mesenchymal stem cell or an MSC, which is the center there. So this is like kind of one of the stem cell types that we're working with most commonly in clinical practice. Now, certainly there are all types of stem cells out there, but these stem cells, which that you can get them from fat tissue, from umbilical cord or placental tissue, from your bone marrow tissue. There's all different ways you can get them. But once you have one of these cells, one of the ways that it talks to your cells is it's releasing these little extracellular vesicles, these little bubble-like things. Exosomes are types of extracellular vesicles. And these EVs, these vesicles, essentially get taken up by your cells, this recipient cell over here, and that changes how your cells make proteins and how they function. okay? So this process here is what pretty well known, but there are a lot of things that we can actually do, like PRP, like shockwave therapy, hyperbaric oxygen, red light therapy, or photobiomodulation, that can affect both stem cells, so make them more active, and also can directly act on recipient cells, on your cells, to affect the protein production. So these are some of the things that we do in practice, and the end goal are the same things we talked about before. So we're trying to reduce oxidation, we're trying to be anti-apoptotic, so reverse or get rid of cell death, we're trying to get rid of scar tissue, get more blood flow, immune modulation is important because the immune system is affecting this tissue, and then support the cells in that area. So this is me, looking a little creepy, but holding a shockwave therapy, a low intensity shockwave therapy device. Do you guys know about these? No? This is one of my favorite tools. Actually, it's been studied much more in men, so I love this therapy for men. But basically, this is a handheld device we use in the office. It's delivering high-pressure sound waves, essentially like acoustic waves, into the tissue. You just put it on your skin. We use it to treat a lot of musculoskeletal pain, Achilles tendonitis and shoulder pain and things like that. But it turns out it's actually really good. And we know this mostly from men, but it works in women too. It's really good for repairing the damage that you have that's causing erectile dysfunction in the tissues, and essentially reversing ED in men. You do a series of treatments, usually about 6, tons of evidence, and about 75% of people who have these sessions, if they're good candidates, will actually have improvement in sexual function in men. There aren't as many studies in women. However, that was one. There are some studies using the same technology in women for arousal disorders, for pain disorders, for this menopausal associated vaginal atrophy kind of disorders as well, and stress urinary incontinence, which is when you laugh or you sneeze and you pee a little bit, very common in women. And this kind of technology is very helpful and is completely safe, which is awesome. There's another one. This is talking about shockwave therapy purpose. So I love that one. We have it in all of our offices. We do it all the time. It's great. Other things, this doesn't have as much research, but there are a couple of papers on this. This is red light therapy for your vagina. So you guys have seen the red light therapy panels, right? We know how they work. We know about the mitochondrial energy production and all the things. Well, there are devices that you can actually use intravaginally that deliver the same kind of light, usually about 600 to 1,000 nanometers, that can have some of the same benefits, we think, in the vagina. So improving sensation, lubrication, stress urinary incontinence. These are home treatments you just do while you're watching Netflix or whatever. And then, of course, there are the regenerative biologics, which, again, not as well studied in women as men. Lots more research in men. But there are some studies, including a systematic review in 2023, using PRP, injecting it into the vagina, basically in the kind of the G-spot area or around the urethra, to try to improve various symptoms. And they do see improvements in female sexual function, in pain, in stress urinary incontinence. And these are treatments that I've done for many years, and they're not always effective, but they are very safe and they can be very effective. And then luckily, we just had a talk about this, but can we rejuvenate the ovaries at this point? And I'm not doing any surgeries on anybody, but certainly there are people that are doing intra-ovarian injections of biologics, like PRP especially, that's the one that's most studied, as well as various types of stem cells. And there are a lot of case reports and small studies and pilot studies. We don't have any randomized controlled trials. We don't have big studies, but the results are pretty encouraging, and these are very safe types of procedures. So I think that it's one of those things that it is possible, especially if you're perimenopausal or early menopausal. You still have follicles when you first start menopause, 1,000 essentially. So if you can potentially get to those follicles early, kind of turn back the clock a little bit, potentially you can start having periods again. Whether or not you're actually going to be fertile, I don't know, but I'm thinking more about the hormonal part of this. And then, of course, the rapamycin study, which is underway right now out of Columbia University. Early results, preliminary results, they reported a lot of improvements in the rate of ovarian aging. That's not published yet, and we don't have the final results yet, but this is something to keep an eye on because, if we can do this with low-dose rapamycin, then that's fantastic for women. All right, in summary, I have 2 very scientific slides. So this is before you start taking care of your sexual health. This is how you feel, okay? And then this This is after.